Everybody?
Yes.
Brilliant. This is a bit longer, but I won't go. I'll just sort of briefly cover the different projects. So this is really a PowerPoint presentation looking at 3 different international collaborative projects and engaging children into healthcare. So there's a real paucity of the literature on how healthcare professionals, industry and organisations actually engage with children and as informants of healthcare delivery. So important concepts to consider are that children's voices are incredibly important to include into healthcare delivery, but there are not many countries that actually do that, and there are also not many countries that have a tool that's been validated by children or developed by children for children to actually have a voice in healthcare delivery. So Lisa Whitehead, who's on today, and I and Diane Arabit developed the Needs of Children's questionnaire, which was developed, as I said, by children for children to have a voice about how their healthcare experience within a hospital. So you can scan that code. It's also an open access manuscript. So please have a look at how this tool was actually developed. It has 4 different categories and there are 16 items. So the categories are caring, information, activities and relationships. And there's an example of one of the statements that the children can answer. It's for school-age children, so 5 up to 16 years of age. And the children score it on a level of importance. So how important was that statement? But also was that need, psychosocial, physical, and emotional need actually met? Because there's been a high correlation between if something's important for a child and it's actually not happening, then that needs to be addressed within healthcare delivery. And there's also an option to collect demographical information on the tour about the child, so their age, hospital admission, ethnicity, and so on, or how many days they stayed in hospital. So, and these are some of the different sorts of demographic data that you can collect. The MCQ Needs of Children's questionnaire is also being translated at the moment in Sweden, Turkey, and Africa. So as I said, there hasn't been a tool that's been developed for children to actually self-report on their hospital experience. So yeah, it's really, really important, I think, to get this tool translated into as many different countries. So for translation, it has to go from the English to, say, Swedish, and then from Swedish back to English, and then it also needs to actually be validated within that Swedish context. So further validation and psychometrics needing to be undertaken. So Professor Evelot Marilius is undertaking the Swedish translation and psychometric testing within Sweden, and also then going to be doing implementation of the Needs of Children's questionnaire in Crown Princess Victoria Children's and Youth Hospital in Liponging. We've also developed some further resources in regards to the Needs of Children's questionnaire, and this is really based on the fact that we're undertaking a study in New South Wales at Liverpool Hospital Children's Ward and looking at the feasibility of implementing the Needs of Children's questionnaire within that hospital. So that's training clinical educators to become competent to be able to undertake the Needs of Children's questionnaire workshops with staff, so that the staff can then become competent NCQ and will be competent in undertaking the Needs of Children's questionnaire with children. So there are quite a lot of things you need to consider, obviously, with undertaking research with children, ethical considerations. So a lot of the workshops, although it's quite brief for the educators, it's 3 online workshops, which I've undertaken with the educators, and then what they do is they undertake the workshop with a group of staff on the ward for them to become competent, and that's just one workshop. And I have joined those workshops as well when they were being undertaken in New South Wales to support the educators, and they did an absolutely amazing job. So that study's now rolling or running at the present time. And those are all the different people that are involved with the study, and it also got funding from ACI in Sydney. So the primary aim really was to evaluate the acceptability and usability of the NCQ and staff NCQ toolkit among staff. They're also collecting further data as a QI project on the self-reported scores of the children from the NCQ. So they're undertaking that analysis in real time and having huddles and being able to actually use that information to provide children on the ward with what the children are saying is important and what has been being met or not. This was the inclusion criteria. The study has taken a lot longer to roll out because of COVID, and also the acuity on the ward is really high over winter, as you could imagine, with the viral illnesses, and now moving into spring, it's going to be asthma. But in saying that, we've got 25 of the 30 staff, 25 have agreed to actually undertake the study or become a participant in the study, and I think there's only one new nurse that still needs to be trained. So we've actually done really well. They're very dedicated, and it's a wonderful project to be involved in. These are some of the learning outcomes for the educators' workshops. And we also had a video that we undertook, a Needs of Children's questionnaire with a 6-year-old child in Australia, and it's actually now a YouTube clip. So I can share these slides with people later, and you can have a look at the YouTube clip and some of these resources, although the resources aren't on here, but you can easily contact myself, Lisa Whitehead or Evelot Morelius to get further information if you'd like to undertake the NCQ, say in Japan. And that these were the NCQ toolkit workshops for educators. And these are our evaluation outcomes in regards to how is it that we're actually evaluating their knowledge for the educators. Sorry, that was the workshops for the staff, and that's how we're evaluating their knowledge in undertaking those staff NCQ workshops. Further projects that are being undertaken at the moment, we're looking at undertaking the NCQ within Christchurch Hospital, Kids First Children's Hospital and Starship Children's Hospital for further psychometric testing. So, and also for cultural responsiveness, because within Auckland there's a high percentage of Maori and Pacific, so it'd be very interesting to know, even though the tool actually was developed in Christchurch Hospital, and then it also had 195 children from Australia and children helped develop the tool. It still needs further testing. So we've done exploratory factor analysis, but now we need to do confirmatory factor analysis on the actual reduced 16-item 4-category tool. Those are some references. And please see our contact details here. So that's my contact detail, Professor Lisa Whitehead, who's on this meeting today, and also Professor Evelot Morelius. So if you would like to know more information about the Needs of Children's questionnaire, if you would like to translate the Needs of Children's questionnaire, then please do contact us, because we're very keen to share our research and see the Needs of Children's questionnaire utilised in more countries. Thank you for listening to my presentation. I hope I didn't talk too long.
Thanks, Manny. No, excellent research and well presented. Thank you very much. And now we'll go to Karen, and then Junko has got a short presentation as well. So I'll hand over to you, Karen.
Hey everyone. So just following on from the SWAY presentation, Elizabeth asked me to share a little bit more around my experience and my research in procedural pain management for children. So as I introduced before, I'm currently working as a lecturer in nursing at Griffith University, but I also have the co-joint position in the Department of Anaesthesia Pain at Queensland's Children's Hospital. So today I just thought I'd talk a little bit about my background, just give you an overview of some of the research that has been undertaken in that space, and really why I think procedural pain is so important. So my background in procedural pain management is I've been doing this for over a decade now, so I'm quite passionate about it. I started when I was at the Royal Children's Hospital Children's Cancer Centre down in Melbourne. I was a nurse consultant there with their procedural pain program. So I worked broadly with all children and their family who needed support for medical procedures because it was quite intense. These kids became very quickly unwell with chemotherapy. And for a lot of these kids, it was quite a long journey as well. So there was a lot of distress for these children, but also a lot of procedural fatigue. I then became quite interested. I was doing my master's in pain management on the pain experience of children undergoing bone marrow transplantation. So I remained at the Children's Cancer Centre there, but then I also took up another position in the Department of Anaesthesia and Pain at Royal Children's Hospital, again as a nurse consultant working in the procedural pain space. And that was quite interesting. These were the kids with more high-end needs, distress. So it was really a great job in terms of being able to use mindfulness of these children, hypnotherapy, doing individual plans. And then ended up here at the Department of Anaesthesia in, once again, looking at that procedural pain space. So procedural pain, it is a short-lived acute pain associated with medical investigations for healthcare, but we often use the term pain and distress intertwined with this because I found, particularly with a lot of the kids that I worked with, like at the end of the procedure, the kids were crying a lot. If I said to them, were you crying because that hurt? You were in pain, or were you crying because you were worried? I could back it in 99% of the time. The children were crying because they were worried. And so, of course, that pain-related fear, anxiety, depression, that can, enhance how their perception of the pain experience, the severity of the pain. So procedural pain, I believe, is really important to make sure that we're doing the best that we can with children, because medical procedures are the most and the most common experiences that children will experience where they do come into hospital, and not just when they're hospitalised, but we look at your outpatient settings as well. That normally involves some type of invasive procedure. And it really is quite a significant cause of pain and distress for children, as indicated by this study by Bernie et al., that the worst pain that they experienced in hospital was because of these medical procedures. And we also need to consider that children have a right to have their pain managed effectively. We do know that this is more than a nice idea. There is a scientific rationale for it, and that if it's not managed effectively, it can actually impact on children's developing nervous systems. And I really think I should have probably put a number 4 there in terms of it really is an act of kindness for us as clinicians and for families if we are managing children's procedural pain, if they are experiencing less distress, it's less traumatic for us. And I was teaching a student in the Child and Family Health Unit just last week, and I was talking about procedural pain management. And this student shared, she said, I hate going to work on the days of doing the vaccination. She said, I hate coming to work and hurting kids. So I'm like, well, there are some simple tips you can use that would make it easier for you, the children and families. So the consequences of procedural pain is that children do have long-term memories that shape their future pain experiences. And when you think of it, if you ask any adult who has a fear of medical procedures, I often don't know when it's happened. They said, I've always felt this way. So it indicates that it probably happened quite early in their life. And this can then impact on avoiding healthcare. I don't know if any of you in the adult setting have come across that, where I've seen patients who don't want to come in and have bypass surgery, for example, because they're terrified of needles. So if we're intervening early and every exposure to a medical procedure is the best possible experience possible for children, then it can have those long-term consequences in not avoiding healthcare. I'm just going to talk through some of the studies that I've been involved with now that you might find interesting. I've put links on there, and like Mandy, I'm happy to share the slides, and there's some QR codes as well. So this one was done in 2013, and this is our Comfort First program. We wanted to evaluate if we were actually meeting our goals and if those goals were in line with what was current best practice at the time. It was so it was an observational study, a prospective cross-sectional, and we looked at children in the day oncology setting. And I think this is a really nice publication that I've shared with people, particularly if they're looking at, they want to know, well, what does high quality pain management look like? And, you know, it outlines, you know, the combination of pharmacological and non-pharmacological interventions that were used. So if anyone's looking at their procedural pain management services, this one could be quite useful. And we also found from this study as well that age was quite a significant predictive distress for these children, and that helped shape our service in terms of triaging care with, you know, newly diagnosed patients, and also that long-term, you know, looking at providing more resources for those younger children. And this is a picture. We used to do this with the kids, the beaded journey. So all those beads that that child's wearing, he's a kid from RCH, actually indicates the medical procedures that they went through during their cancer treatment. And some of these are a good couple of meters long by the time they're done. So it just really highlights how much these children do experience in terms of procedures during their treatment. So another study I was involved with, it was a co-design process. We wanted to look at developing up an online, like an e-learning program for healthcare providers to help them with managing children's procedures. It's been hosted by EviQ, so that is a cancer network, but we did write it that it could be used by any healthcare provider, and even families if they wanted to, like it's freely accessible. So that was a really interesting experience in terms of working with families. We did focus groups and interviews with families and children, and also with healthcare providers, and formed a key stakeholder group. And so like this is still there available if you wanted to learn more about it, that's how we created the modules. But then it was really interesting as well. It then went on to inform our clinical practice guidelines for the Royal Children's Hospital, and a lot of the language that's used in that is related back to what, you know, the families and the children said that was really important to them. So you can also have a look at that guideline. I think it's now been superseded. This is the original one that basically I put forward that from this work, that we had the 6 Ps, the planning, preparation, pharmacological, physical, psychological, and promoting recovery and resilience, that, you know, we should be looking at incorporating with all children's medical procedures. Another study, then moving on chronologically, was I was part of the team that implemented virtual reality for children undergoing needle procedures. So this was quite an interesting study in terms that it was actually 2 concurrent randomized control trials. So we had one in the emergency department, and then we had at Monash Uni, and then we had one in the outpatient at Royal Children's. And what was also unique about this study, that actually included children as young as 4 years of age, and often they're precluded from research just in terms of their ability to communicate verbally about their pain. And we found that it did significantly reduce needle pain, anxiety, and distress, and also the need for restraint for both of these groups. And, you know, doing the preparation of this study was quite interesting, being down there, seeing it being used in action. There were so many kids that, anecdotally, from my experience, it's like if we didn't have this, either the procedure wouldn't have got done or the kids would have been held down, which would have contributed to pain-related distress and trauma. And it's really nice now that I'm at the Children's Hospital in Brisbane. I can see Smiley Scope, which is what the team went on to develop, is used quite extensively in clinical practice, and also like down in Melbourne with all the lockdowns of COVID, really used extensively in the vaccination centres as well. So I'm still doing some more work in that space. So the next study I want to share with you is actually from my doctoral studies, where I was looking at more broadly in the pain experience of children undergoing bone marrow transplant, or the more technical term, hematopoietic stem cell transplantation. And procedural pain was quite a significant contributor to children's pain experience. there were three key contributors. One was those painful complications related to the cancer treatment itself. There was the medical procedures, and then there was also this distinct entity of psychological pain, and medical procedures often featured in that as well. So even though the pain was short-lived, it was often described as the worst and hardest of the painful experiences for children. And this is because we had invasive and repetitive intervention. So it's this quote, it was from one child, and this was all in a 2-hour period. So as I said, it's only 11 in the morning, and this child's already had 2 nasal washouts, a dressing change, which he hates the most, and then nasogastric tube tape changes. All of them hurt and just really distress him. The other issue was also the anticipatory anxiety, because these children were cared for in protective isolation. So everything happened in that one room, you know, the good, the bad. So as soon as someone entered the room, they'd be like, what's going to happen next? And just sharing some other work that we've done with the COVID-19 vaccinations for children. That's kind of reignited an interest in children's, how we manage children's medical procedures. So you're welcome to have listened to this. I was interviewed on ABC Brisbane around some tips and tricks on how to actually help children cope with the vaccinations, because this is interesting. Like, we've got younger children from 5 years of age, and with the COVID vaccinations as well, they need their first experience is, you know, a reasonable one, because remembering that a lot of the vaccinations in children happen when they're infants, so they may not have that memory of what, you know, of what an actual needle procedure is. And the other one we did was with the conversation with rapid antigen tests in children under 2 years of age, where we discuss the evidence for doing RAT tests in these children and some tips and tricks, once again, for parents if they needed to do a RAT test for their child, you know, how to approach it to minimise pain and distress for the little ones. So just to finish off, just some of the studies that we've got coming up. We've got a one that's about to start, looking at the evaluation of nurse practitioner-led procedural support service for children. So this is a unique service which was formed in response to COVID-19 and children who just could not be vaccinated due to high-end distress. So these are kids that we actually need to sedate, often with dual agents. So we've got nitrous and then an oral sedative as well. So we're going to look at the safety of that service, outcomes for children, and how we can optimise that service for the future. We're also looking, this one's already started, but we're looking at building on as well, virtual reality for burns dressing, which is unique because a lot of the virtual reality work is done with really short, you know, procedures such as needle intervention. So this is for more prolonged procedure. Also have a couple of systematic reviews happening with psychosocial interventions for pain in children with cancer, and also digital health interventions for children's post-op recovery. And we've also implemented a new procedural pain framework at the children's here called CALM. So that's comfort, analgesia, language, and mindfulness. So we're looking at how, because a lot of procedural pain management barriers are around changing behaviour. So we've just started having conversations around a procedural pain management simulation-based learning program. So that's really all I wanted to share. So hopefully I've convinced you, if you weren't already convinced, I'm sure you already are, that it's really important that you manage children's medical procedures well, and they don't necessarily have to hurt. So this is a little video. I won't play it now for time, but please feel free to go off and watch it yourself. It's really, I really love it. It's coming from a child themselves, giving advice to adults around it doesn't have to hurt her, and there are some things you can do to make sure that it doesn't. Yeah. No, it's going to play.
Thanks, Mandy. That's not Mandy, Karen. Excellent presentation, and yeah, it's such a valuable research that you do as well to try and hopefully